How's it going, guys? We have a medium difficulty question for pharmacology for step one. You are going to see this question, an iteration of this stem right here across the NBME exams for step one repeatedly, okay? Not my fucking opinion, all right? So I will keep this real clean and concise, tell you exactly what you need to know, because this discussion of the physiology and the pharm and the kidney can get very fucking complicated very fucking fast, okay? So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at Mehlman_medical, Mehlman_medical. Link is down below. Find me on Telegram. Recently created Telegram group and channel. Links are down below. Now let's start the clip here. So we have a 61-year-old man, biventricular heart failure and hypertension. He's commenced on furosemide therapy for the management of his peripheral edema. 4 days later, the edema is not resolved. And the question wants to know, what drug are we going to add to this patient's regimen to improve his edema? Okay, and as I prefaced with, I'm going to keep this real concise here. The patient's already on a loop diuretic. You need furosemide. You need to know loop diuretics are the most efficacious for fluid unloading, whether it be peripheral edema or pulmonary edema. Okay, they block the 1 sodium, 1 potassium, 2 chloride symporter on the apical membrane of the thick ascending loop of Henle. And as a result of that, they are causing potassium wasting. Okay, you're clearly blocking potassium reabsorption. But in addition, because you are dropping intravascular fluid status as a result of giving the loop diuretic, that will cause an upregulation of RAS, renin-angiotensin system. Aldosterone causes potassium secretion distally in the kidney, in the cortical collecting duct. So not only are you blocking the reabsorption of potassium directly in the thick ascending limb, but you're also causing potassium secretion distally in the kidney. Potassium wasting, okay, loop diuretics. Thiazide diuretics, they block the 1 sodium, 1 chloride symporter on the apical membrane of the early DCT. They're not blocking potassium reabsorption directly, clearly, but the drop in fluid status, similar to loop diuretics, will cause upregulation of RAS and potassium secretion distally in the kidney, okay? So my point of consolidation for the moment is both loops and thiazides cause potassium wasting, and upregulation of RAS, where we have potassium secretion distally, it's an important mechanism, okay? Now, we need to give this patient an extra diuretic to unload more fluid, but we don't want to risk dropping the patient's potassium any further, okay? Potassium can still be in the normal range, but if we add another diuretic, we want it to be a potassium-sparing diuretic, okay? Now, there's 2 main classes of potassium-sparing diuretics USMLE wants you to know. You either have the aldosterone receptor antagonists, i.e. spironolactone, eplerenone, or you've got the enoch inhibitors, which are amiloride, triamterene, okay? So sometimes they'll give you the same fucking vignette, and they'll say, what drug are you going to add now? And the answer will just be spironolactone, that's it, okay? Or answer, triamterene, that's it. Or amiloride, that's it, okay? As I said, there's many iterations of this question, and that's easy when they just ask you the drug straight up, because you want to give a potassium-sparing diuretic if you're already on a potassium wasting diuretic, okay? You're not going to add a thiazide to a patient who's already on a loop diuretic, okay? You can cause hypokalemia. So we say, well, which one of these is going to apply to spironolactone, eplerenone, triamterene, amiloride? And the answer is choice B, decreases collecting duct luminal permeability to sodium. This is going to be an enoch inhibitor, okay? Amiloride or triamterene. Now, if you block aldosterone effect at the cortical collecting duct, aldosterone with spironolactone and eplerenone, that will decrease activity of the basolateral sodium-potassium ATPase pump, and indirectly, that will lead to decreased enoch activation on the apical membrane. But the point is, enoch inhibitors, okay? I mean, this is the next drug we want to give, or an aldosterone receptor antagonist, not an answer given here, okay? So choice B is our answer. Let's just look at the other answer choices. Choice E, inhibition of distal convoluted tubule sodium chloride symport. Wrong answer. This is thiazides. We're not going to add one, as I just said. Choice D, inhibition of calcium channels within vascular smooth muscle. Wrong answer. This could refer to dihydropyridine calcium channel blockers, i.e. nifedipine and amlodipine. These can actually cause peripheral edema. Okay, these can cause peripheral edema, fluid retention. High yield for failure medicine for 2CK. Choice C, decreases collecting duct aquaporin insertion. This could be vasopressin receptor antagonists. Okay, so conivaptan, tolvaptan. low yield drugs, okay, but you need to know aquaporin insertions via ADH, okay, not aldosterone. Choice A blocks the alpha adrenergic receptors. I mean, obviously tamsulosin, terazosin for alpha 1 blockade for BPH, or just prazosin peripherally, phenoxybenzamine, irreversible for pheochromocytoma. Okay, those are all alpha 1 blockers used for hypertension. That's pretty much it. I don't want to get too crazy tangential. So look, that's your question here. If you're on a loop diuretic already and you're going to add another one, you're going to enhance fluid unloading. You're going to give a potassium sparing diuretic, okay? And it's going to be an aldosterone receptor antagonist, spironolactone or eplerenone, or an enoch inhibitor such as amiloride or triamterene. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.